sabay nating hinarap ang pagsubok at paghirap hanggang makamtan natin ang matinyas nating pangarap. Pagsikat ng liwanag sa unang araw ng Mayo, sa taon na tinadhana bilang ating sentenaryo, ay biglang natapos din 5 taon ng pagsisikap, 5 taon ng pagsasama sa oras ng saya't hirap. Tayo ang class ng 98, sa simula nakakitang nilas sa loob ng PGH, kay busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98. Hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento? Ilang dekada bang tayo'y magkakasama? Sabay-sabay tayo yumapak sa landas ng pagkakaisa. Sabay nating harapin tagumpay ng ating mithiin, karangalan at galing sa lahat ng ating gawain. Pagsikat ng liwanag sa bawat araw ng taon, pasalamatan natin Diyos na Panginoon sa alaala't kwento natin ng katuwa at bigati sa lahat ng pangyayari na naghubog sa atin. Tayo ang class ng 98, sa simula nakakitang nilas sa loob ng PGH, kay busilak ng utak at puso. Kailan ba'y di nagkulang sa talino at talento? Tayo ang class ng 98. Hanggang ngayon may pakitang gilas. Salamat PGH, mayaman sa utak at puso. Kailan ba'y di nagkulang sa talino at talento?
Welcome to the UP College of Medicine Class of 1998 webinar series. As this year's Silver Jubilarians, our class is hosting most of the webinars this year on Mondays, Wednesdays, and Fridays, unless announced otherwise. Coming from our successful webinars last year, our 2023 theme is still primary health care in the era of universal health care. In this current webinar series, we hope to unlock knowledge and discuss interesting and relevant topics for primary care physicians, including GPs, family and community medicine physicians, occupational and industrial health physicians, as well as other allied medical professionals. Here are some reminders for a smooth webinar experience. Firstly, kindly turn off your microphone and video for the duration of the webinar. Secondly, we encourage you to participate in an interactive discussion at the end of the speaker's presentation. Feel free to type in your questions in the Q&A chat box in Zoom or through the comment section if you are watching on Facebook. They will be addressed in the open forum after the lecture. Let us now begin with a short ecumenical prayer. Almighty Father, we praise and thank you for this day. We come to you asking for blessings and help for our speaker, moderator, and everyone present right now. We pray for your guidance as we unlock knowledge together. We ask that you show us how to conduct our work clearly and with a spirit of joy and enthusiasm. Protect us from the illness of apathy and hopelessness. Instead, keep the fire and love in our hearts as we work together with our colleagues. We ask that you challenge us to reach higher and further to be the best we can be for others. Amen.
Hello, good afternoon, everyone. Everyone who is here on Zoom and everyone who is watching on Facebook and in the UP Manila live stream. Before we proceed, let me introduce myself. I am Dr. Miko Oring Palo. I will be your moderator for this afternoon session. I am a pediatrician at the St. Luke's Medical Center in Global City. But more importantly, for today, I am a member of the UP College of Medicine class of 1998. And we are hosting this webinar series as part of our Silver Jubilee this year. Allow me to introduce our esteemed guest speaker, Dr. Ausencio Lawrence Lucero Jr. He is an associate professor and the rheumatology section chief at the De La Salle Medical and Health Sciences Institute, and he is also the internal medicine department chair and rheumatology section chief at the San Juan de Dios Hospital. Today, Dr. Lucero will talk about the impact of osteoarthritis on patients. Thank you for taking time out to join us today, Dr. Lucero. You may take the virtual floor.
So good morning, everyone. First off, before I begin, I'd like to take this opportunity to thank the organizing committee, UPMAS, for inviting me to be a part of this webinar series. And I'd also like to thank Viatris for sponsoring this lecture today. So the topic that was assigned to me is shown in your screen, OA to OK, recognizing the impact of osteoarthritis on patients. So these are my objectives for today. First, I will describe to you the burden of disease of osteoarthritis, as well as the clinical manifestations associated with this condition, and what are the risk factors associated with the condition, and what are the common differential diagnoses that you can think of in patients with osteoarthritis. And then we will segue into discussing treatment with special emphasis on non-pharmacologic and pharmacologic therapy. And I will discuss to you this early OA concept, which is an emerging concept in rheumatology that may have an impact in the way we evaluate and treat patients with OA in the future. So this is the flow of my discussion. So let's begin with the burden of disease. So osteoarthritis is the most common arthritic condition worldwide. In the most recent study by the Global Burden of Disease study for 2021, but which was just published a few weeks back, the prevalence of symptomatic OA is placed at around 7.6%. So in 2020, around 595 million people were affected with this condition, predominantly in females, and the most common joints involved are the knees, hands, and hips. Now, the increase in the prevalence of OA actually represents a 130% plus increase from 1990 of around 256 million to 595 million in the most recent data. And this is still projected to increase to 1.1 billion in 2050. Now, the global burden of disease of OA remains significant. In 2020, it is responsible for 21.7 million years of living with disability, and this represents an increase of more than 130% since 1990. Overall, OA ranks 14th globally for all ages in terms of contribution to disability worldwide. But among the elderly population, particularly those 70 years old and above, it is ranked within the top 10. And among the different joints that contribute significantly, it is knee osteoarthritis that contributes significantly to disability. Now, we do have our own data in the Philippines. So in the most recent study by the National Nutrition and Health Survey, way back in 2003, the prevalence of OA is placed at around 0.5%. So according to this data, it is the third most common arthritic condition in the country behind gout and rheumatoid arthritis. And this is in contrast to two previous studies by the CAPGORD in 1991, where they did the study in a rural setting, and in 1997, where they did the study in an urban setting. And in both studies, it was clearly shown that OA is the most prevalent arthritic condition in the country. And probably the reason why there's a difference between these three studies is because of the different methodologies adopted in the study. But what is apparent in these three different studies is that there is an increasing prevalence with age. It is more common in the middle age to the elderly population. We seldom see OA in patients below 40 years old, and it's more common in patients 60 years old and above. And among the Filipinos, the most common joints involved are the knees, hands, and spine. So seldom do we see involvement of the hips, ankles, and shoulders. And the most common clinical presentation is monoarticular involvement. Now, the prevalence of OA is still expected to increase in the coming years. And this is because of three factors: the continuing population growth worldwide, the aging phenomenon, and the increase in obesity. So for the elderly population, it is projected that by 2050, the elderly population will be about 2 billion, which is double to the population in 2020, and the Philippines will contribute significantly to this elderly population. For obesity prevalence, since year 2000, according to the WHO criteria, it has increased from 8.3% to 13.2%. And this is also true in the Philippine population. So what we're seeing here is that osteoarthritis will remain a major public health issue in the coming decades. So what do we now know about osteoarthritis? So let me just correct a common misnomer. So we don't see OA anymore as a simple degenerative joint disease or a simple wear and tear disease. What we know now is that OA is a failure of the synovial joint as an organ, and therefore it does not only involve the articular cartilage, but also other tissues like the subchondral bone, the synovium, and all the periarticular tissues in the synovial joint. And we now know that this is an interplay among different factors like mechanical, inflammatory, and metabolic factors. So let me just show you a little bit and explain what we know now about osteoarthritis. So the three important tissues that has an impact on osteoarthritis progression are your cartilage, subchondral bone, and the synovium. And there seems to be a molecular crosstalk between these three tissues that produces pro-inflammatory cytokines that overwhelms the production of anti-inflammatory cytokines. So what you basically have is that you have a condition that is something like a smoldering disease that slowly progresses through the years. So how does it present clinically? So the most common reason why patients come to the clinic is because of joint pains. And in the beginning, when the organ reserve is still very much intact or near normal, then pain occurrence is usually few and far between and of short duration. However, if the organ reserves continues to diminish, pain becomes more frequent and longer lasting until such a time that it reaches a critical organ reserve decrease, and therefore your patients will experience constant pain from there on. Okay? So the common symptom that the patient will tell you is that they have stiffness either when they wake up in the morning or after inactivity, and it doesn't last beyond 30 minutes. And they will share that it is aggravated by prolonged use like walking, standing, or squatting, and it is relieved by rest. If you do physical examination, you will appreciate crepitation, bone enlargement, limitation of movement of the involved joint. And if you touch it, you might feel some warmth. And if you press it, you might feel a little bit of tenderness. So just to show you a bone enlargement, which involves the hand. So if you see bone enlargement in the distal interphalangeal joint, then we call this Heberden's nodes. And if it occurs in the proximal interphalangeal joint, then we call it Bouchard's nodes. Now, I've already discussed the two most important risk factors associated with OA. Age is the most strongly correlated. As I've said, both worldwide and in the Philippines, it's more common among the middle-aged to the elderly population. In terms of obesity, there are two mechanisms that we're looking at. For the weight-bearing joints, it is most likely due to the biomechanical effect of the weight. For the non-weight-bearing joints, research tells us that it is most likely due to the effect of adipokines, particularly leptins. It is more common among the female, and there seems to be a genetic predisposition for osteoarthritis. And this is based on twin and population-based studies using radiographic osteoarthritis as the surrogate marker. So according to these studies, genetic predisposition for the hand is around 60%. For the knee, it's around 40%. For the hip, it's 60%. And for the spines, it's 75%. For anatomic factors, joint malalignment such as varus and valgus deformity and joint incongruence can predispose patients to develop osteoarthritis. Manual or exposure to manual labor because of heavier loads and longer duration of exposure can also lead to osteoarthritis, as well as exposure to sports and prior injuries because of sports-related injury can also lead to osteoarthritis. For injuries that may be related to sports or even non-sports, the mechanism there is because of the acute mechanical damage brought on by the injury, as well as the chronic abnormal joint loading and the altered neuromuscular control that can occur after the injury. So just to show you a picture of the joint malalignment. So the one on your left is what we call genovarus or bow-leggedness. Okay? And the one on the right would be your knock-kneed appearance or genovalgus. And also shown in this picture is the bony hypertrophy of both knees. So how do we diagnose osteoarthritis? So way back in the mid-80s to the early 90s, the American College of Rheumatology published a criteria for osteoarthritis as shown in the screen. However, you don't need to memorize this one because this criteria is actually a classification criteria which is more useful in research. And in fact, this has been the criteria used in the Kapcord studies. Okay? However, in 2009, the European League Against Rheumatism published a diagnostic criteria for knee and hand OA. This one we can actually apply these criteria for diagnosing patients in the clinic. But what it tells us is that if your patients have a lot of these knee or hand symptoms and signs, plus associated risk factors such as those listed here, then the probability of a correct diagnosis increases. And as you can see here, you actually don't need to do a lot of blood tests or x-ray to be able to diagnose patients with osteoarthritis. So according to the Euler diagnostic criteria, for example, in the knee, if you have all the three symptoms and all the three signs, then the probability of a correct diagnosis increases to 99%. And therefore, you don't need an x-ray to be able to diagnose your patients. However, if you need to do an x-ray, the most common findings would be in these pictures. Okay, so presence of osteophytes, joint space narrowing, presence of subchondral sclerosis, and subchondral cyst. The only time you probably would need to request for an x-ray would be when you're thinking of an alternative diagnosis or when you have already optimized medical management for your patient, but still patient complains of pain, or if there is an atypical presentation for your patient. So what are the common differential diagnoses for OA? It can be RA or rheumatoid arthritis, gout, or septic arthritis. So let us just go through the features of osteoarthritis again. So as I have said, it is more common in the middle age to the elderly population, more common in females. And when it presents in the clinic, it is usually asymmetric. Patients may have already chronic monoarticular arthritis, and if you ask the patient will tell you there's stiffness but doesn't last beyond 30 minutes, and it gets worse with use. And since it is almost mildly inflammatory, no systemic symptoms will usually be mentioned by the patient. The most common joints involved are the weight-bearing joints, but as I have shown you in the previous slide, it can also involve the hands, particularly the distal interphalangeal joint and the proximal interphalangeal joint. And laboratory findings are usually normal, so there's really no need to do a lot of tests for patients with osteoarthritis. And if effusion is present, a synovial fluid analysis will reveal a non-inflammatory character of the fluid. So how do you differentiate this with RA? So probably what's in your mind is the typical presentation of RA, where you already have a symmetrical polyarticular manifestation in your patient, presenting with morning stiffness lasting beyond 1 hour, and then it improves with the use. And because it is oligo to polyarticular in presentation, you can have systemic symptoms. And the most common joints involved are the small joints of the hands and feet, but it can also involve the large joints. And if you do blood tests, you will be able to detect rheumatoid factor or anti-CCP and even elevated acute phase reactants. And synovial fluid analysis will reveal an inflammatory character. Now, usually for RA, sometimes they begin with a monoarticular, particularly in the earliest stage of RA. And in this presentation, you might mistake it as an osteoarthritis. For gout, okay, so we know that it is more common among males, particularly middle-aged men. For women, it's more common for postmenopausal females. The common presentation would be a monoarticular involvement, which is sudden in presentation with severe pain and usually involves joints in the lower extremities. But 60% of the time, the first occurrence occur in the first metatarsophalangeal joint, or what we call podagra. And if you do blood tests for these patients, you can appreciate an elevated uric acid or an elevated acute phase reactants. And definite diagnosis for gout would be identification of the monosodium urate crystal in the synovial fluid. And since if you do synovial fluid analysis, the character would also be inflammatory. Now, septic arthritis can also be a differential diagnosis for your patient because in 80% of the time, septic arthritis present as a monoarticular involvement. But since it is an infection, you can have systemic symptoms in these patients. It's more common among the elderly population, in the immunocompromised patients, and those taking immunosuppressive drugs. And usually it involves the large joints or those with pre-existing joint disease, such as those already having rheumatoid arthritis or osteoarthritis, and those with prosthetic joints. And if you do lab testing, your synovial fluid or your blood might turn up or turn positive for culture, as well as an elevated acute phase reactants. And if you do a synovial fluid analysis, you might see a WBC count of at least 50,000 or more. And if you see this type of account in the synovial fluid analysis, then you have to think that there might be a coexisting septic arthritis in your patient. Septic arthritis can occur even in patients with gout, rheumatoid arthritis, or osteoarthritis. So how do we treat patients with osteoarthritis? So there's been several treatment guidelines that have been published. For the Philippine Rheumatology Association, we published a guideline way back in 2008. Before the pandemic started, there were 3 important treatment guidelines that were published in the Western or by the Western organization, such as those coming from Europe, the ESEO, the International Group ORC, and from US, the ACR. And in 2021, during the pandemic, there was one treatment guideline that was published in this part of the world, published by the Southeast Asian Working Group, where you also had several Filipino rheumatologists who also took part in drafting this treatment guideline. However, this 2021 working group treatment guideline is actually a reflection of the ESEO treatment guideline published in 2019. So we will discuss the common ground for these treatment guidelines. So in all treatment guidelines, the goals of treatment are to alleviate pain, improve function as much as possible of the involved joint, and to delay the progression of the condition. And treatment can range from non-pharmacologic to pharmacologic to surgical management. But for this talk, I will be concentrating my discussion on the first 2 only. So for non-pharmacologic treatment, probably a lot of you are thinking that pharmacologic treatment is the main core of treatment. But in osteoarthritis, what is the main core of treatment is actually the non-pharmacologic management. And in all of these treatment guidelines, it has been emphasized that education, exercise, and weight loss should be emphasized in the management of the patient. So for education, in Western countries, they have what we call self-management programs, wherein patients enroll in a formal class where they are taught about the condition and how they can manage their disease. In the Philippines, we do not have these formal classes, but what we have is a standard clinic encounter. What we do in the clinic already, we already tell the patient what they have and what they can do to manage before they probably come back to us for further evaluation and management. For a lot of these treatment guidelines, for exercise, it is mostly land-based, involving low-impact aerobics, strengthening exercises, and neuromuscular training. And according to research, the least or the minimum weight loss that has been found to have a significant impact on pain and function is at least 5% of the present body weight. Other non-pharmacologic measures that has been recommended are your gait aids, use of acupuncture, tai chi or yoga, thermal therapy such as cold and warm compress, and if available, the use of cognitive behavioral therapy. So this is a summary of the non-pharmacologic measures among the different treatment guidelines that I have discussed. For the pharmacologic treatment, it should be seen as an essential adjunct, particularly in the management of symptomatic OA. So among the different treatment guidelines, treatment or pharmacologic treatment can be divided into three: analgesic, intra-articular injections, and nutraceuticals. So let's begin with analgesics. So paracetamol used to be the first line of treatment for osteoarthritis. However, in the recent past, its efficacy and safety has been put into question. So there's been a lot of network meta-analysis published showing that paracetamol is the least effective analgesic in the management of pain for patients with osteoarthritis, and there seems to be no significant impact on function in these patients. And second, there's been observational studies that shows that use of higher doses of OA, more than 3 grams per day, actually has an impact on the cardiovascular, gastrointestinal, and renal organs. However, in 2019, a meta-analysis was published in Cochrane where they combined 10 randomized controlled trials of patients diagnosed to have knee or hip OA and comparing the adverse events in patients given paracetamol and placebo. And the outcome here shows that there was actually no difference between paracetamol and placebo in terms of adverse events. And so the conclusion of the authors is that overall, paracetamol still considered safer compared to your NSAIDs. And so the recommendation in the treatment guideline is that if you're going to use paracetamol, use a lower dose, 3 grams or less, as a short-term rescue analgesic or as an alternative to your NSAID. For NSAIDs, these are now the first line of treatment, particularly in patients with moderate to severe pain. And the guideline tells us that all NSAIDs should be given at the lowest dose that is effective for the management of pain at the shortest possible time. And all NSAIDs from different meta-analysis shows that they have the potential to cause cardiovascular, GI, and renal adverse events. There's been some guideline in the different treatment guidelines on how to use your oral NSAIDs. For those who do not have any comorbidity, then you can use any of the NSAIDs available, whether this is a non-selective NSAID or a selective COX-2 inhibitor. In patients who are at high risk for GI complications, then use a selective COX-2 inhibitor with or without a proton pump inhibitor, or a non-selective NSAID with a proton pump inhibitor. If your patient is at increased risk for cardiovascular complication, then caution with the use of any NSAIDs. If there is a need to give NSAID to your patient, then might as well choose the one with the most favorable safety profile. And like all other recommendations for NSAIDs, use the lowest dose at the shortest time to control symptoms. And if your patients are at increased risk for renal complication, then might as well avoid the use of your NSAIDs. For the elderly, particularly those 70 years old and above, those who are very frail and those with significant comorbidities, you might as well start with topical NSAIDs. So studies have shown that your topical NSAID is as efficacious as the oral NSAID, but with a safer profile. You can also use the atypical opioid tramadol in patients who have inadequate response or unable to tolerate or have contraindication with the use of the NSAID. And if your patient already has pain sensitization and even depression, then you can add duloxetine. For intra-articular injections, okay, the treatment recommendation only recommend two injections, the use of steroids and hyaluronic acid. For steroids, it can be used in patients with either one or a few joint involvement, especially those with inflammation and effusion. And studies have shown that they can provide short-term pain relief. For hyaluronic acid, you can give this to patients, particularly elderly patients who are symptomatic despite medical management or who have contraindications with the use of NSAIDs, or either awaiting surgery or refusing surgical management for their osteoarthritis. And different meta-analyses have shown that they are effective in reducing pain and improving function in patients with knee osteoarthritis up to 6 months. And this is true whether the preparation is single injection, 3-weekly injection, or 5-weekly injection. Now, for nutraceuticals, there are only 3 that are available in the Philippines: glucosamine, chondroitin, and the avocado soy oil, unsaponifiable. So let's begin with glucosamine. So there's been much debate on glucosamine because there are 2 salts available, the hydrochloride salt and the sulfate salt. But what is apparent in the different meta-analysis is that only the glucosamine sulfate has shown consistent positive results. And so in the treatment recommendation, if you're going to prescribe glucosamine, might as well prescribe the pharmaceutical grade crystalline glucosamine sulfate for OA. There's also been weak recommendation for the prescription of chondroitin sulfate, particularly the pharmaceutical grade, in patients who have hand OA, and in patients with knee OA, there's also a weak recommendation for the use of the avocado and soy oil unsaponifiable. So this is a summary of the pharmacologic recommendation of the treatment of the different treatment guidelines. Now, if all else fails, or despite optimum medical management, your patient remains symptomatic, then might as well refer your patient to our orthopedic surgeon colleagues. Now, earlier, I was sharing to you that there's an emerging concept of early osteoarthritis in the management of OA, and I will be discussing this one because it will certainly have an impact in the way we manage OA in the future. But to help us understand this concept, let me define just 2 terms: disease versus illness. So disease is the abnormality of structure and function, and illness is the way we respond to that disease. So if we put this in the context of osteoarthritis, disease would be your joint space narrowing or the presence of osteophytes and the limitation of movement of the involved joint. And for illness, this would be the joint pain. Okay? A lot of times in osteoarthritis, they do occur together. However, research are telling us now that in the early phase of osteoarthritis, there can be an instance where your patient already have the disease, but they do not have any illness yet. So in this context, we can actually define early OA as the asymptomatic disease state. So let me just focus now your attention to this figure on the right side of your screen. So we now know that osteoarthritis begins as a molecular abnormality that can occur many years or even decades before an illness or a disease manifests in your patient. And so if we look at it this way, it can now make sense that sometimes you have a patient, for example, complaining of a knee pain, but if you do an X-ray, you actually don't see anything yet. Okay, so this may or may not be an OA, and therefore the research on early OA will help us understand whether we can already intervene on these patients. Now, there can also be situations wherein your patient have an incidental finding of, let's say, knee OA, but if you ask the patient doesn't feel anything, or there's actually no limitation of movement of the involved joint. And again, this is an example of an early OA. So basically what it is telling us is that there might be a window of opportunity where we can intervene much earlier in the course of the disease to actually have an impact in the course of the osteoarthritis and therefore have better treatment outcomes for these patients. And so if we look early OA this way, then we can now understand that OA has 4 stages. So for stage 1, it is the no disease, no illness stage. For stage 2, it is the subclinical disease, no disease, and no illness stage. For stage 3, it is the clinical disease illness stage where we see most of our patients in the clinic. And the last stage would be your end stage OA. And so if we understand it this way, we can now understand that there will be different treatment strategies for each of these stages of the condition. So for the first stage, primary prevention will play an important role. What is probably more important here is health promotion. For example, identifying risk factors that are already present in your patients like obesity or overweight, or preventing injury in patients who are engaged probably in sports. For stage 2, what is more important here is secondary prevention. What is important would be to detect and treat the condition as early as possible and prevent the progression of the condition to a more advanced stage. And for stage 3, where we manage our patients at the present, majority of them at this stage, what we can do is a tertiary prevention and to try to reduce damage as much as possible and to prolong their stage at stage 3 and before it reaches the end stage OA, where the most logical management would be joint replacement. Okay. So this is the end of my slide. So let me just recapitulate to you what we have discussed this morning. So OA will remain a major public health issue in the coming years because of 3 factors: the continuing population growth, the aging population, and the obesity pandemic. We now see OA as a failure of the synovial joint and not as a simple wear and tear disease. And diagnosis of OA doesn't require a lot of blood tests or X-ray. Diagnosis is mainly clinical. And treatment, the ones we have as of now are mainly symptomatic in nature and therefore palliative. And lastly, the concept of early OA is telling us that there might be a window of opportunity to have a better treatment outcome for our patient. So with that, thank you for listening and good day.
Hi, thank you, Dr. Chito, for a very enlightening lecture. I am sure that this is very helpful for us, not just as doctors, but for ourselves too, as we all are beginning to approach middle age. Let me begin our open forum. But before that, I'd like to thank our sponsor, Viatris, for helping make this webinar possible. So let me just look at our Q&A box. There are several questions here, sir, about treatment. So let me just start with the first one about febuxostat. Does it play a role in controlling pain in osteoarthritis?
Actually, for osteoarthritis, there's actually no role for febuxostat unless there is the OA is actually secondary to an inflammatory arthritis like gout. So gout can actually predispose patients to have secondary osteoarthritis. In this particular case, you can use febuxostat to control the gout, but not the pain for osteoarthritis.
And so as a corollary, there's another related question. Does hyperuricemia trigger osteoarthritis? And you had alluded to that it might play a role.
For asymptomatic hyperuricemia, meaning this patient doesn't have gout yet, it doesn't trigger OA. But as I've said, once the patient already has an established gout and the gout remains untreated with repeated inflammation of joints, then it can predispose to a secondary type of osteoarthritis.
Thank you. Sir, what about glucosamine? Well, you said pharmacologic grade glucosamine does help, but what about turmeric?
Turmeric, there are some studies that show there is efficacy for that, but I think the studies involving the use of turmeric are still few and far between, and hence they have not yet permeated into a lot of the treatment guidelines. We should see this probably in the future as more research goes into this effort.
Can colchicine address non-gout attacks or seemingly osteoarthritic attacks?
Actually, colchicine has been used as a treatment for gout, and studies have shown that it is not actually effective in managing pain in osteoarthritis. However, it can be used as a prophylactic medication for patients with diagnosed gout.
Established gout, I see. Let's see. You mentioned about thermal treatment. Which thermal compress is better? No heat? Oh, sorry. Let me see if I can understand this question correctly. Warm or cold? I guess that's the simplest way.
Yeah. Basically, it's a matter of timing. If the onset is actually acute, you want to control the inflammation as early as possible, then the best thing to use would be cold compress. And then if patient already has a chronic pain, then these patients will probably complain of stiffness. And to lessen that stiffness, you need to apply heat for that to lessen the stiffness of the joints and the ligaments and tendons.
The next question that we have is about when you already have diagnosed osteoarthritis, is it considered irreversible, and will a knee or a hip replacement become inevitable?
Okay, so let me just put a positive spin on this question kasi parang based on my lecture, parang once you, yeah, it's you're bound to have OA for life. So OA, there's no cure for OA yet, but we do have treatment that can control pain and as much as possible delay the progression of OA. As I've said, the main core of treatment of OA is the non-pharmacologic. So if we're identifying risk factors for these patients, then we can actually do something about it. And it's not an inevitable thing that once you are diagnosed with OA, then you will eventually go into a knee replacement or hip replacement. So there's something you can do about it to delay the progression of the condition.
Well, this is a personal question since I saw on your lecture that the recommended treatment is mostly land-based. Is there very little evidence then for swimming as advice for exercise?
Actually, the only reason why most of the treatment guidelines recommend land-based is because this is the most accessible for a lot of patients. But they also recommend, if available, alternative exercises. So swimming is one of them. Water aerobics would be one of them. And the reason for this is because it has lower impact on the joints, particularly of the limb joints. And so if this is available in your area, then this is still a form of exercise and it can help your osteoarthritis.
Okay. Thank you for clarifying that. Next question. What about collagen supplementation? Can it be used as well, or other anti-inflammatories like, I'm not familiar with this, curcumin longa, turmeric, you had already answered that, or black pepper?
I think just like turmeric, there's still not enough evidence to support or recommend the use of collagen supplementations.
Okay. What about osteoarthritis in the elbow? That's not very common, but is that what is the differential diagnosis for arthritis or involvement of the elbow?
Okay, probably any joint can have osteoarthritis, as the global data would show the most common joints involved are the knees, hands, and hips. And it's almost the same in the Philippines, but instead of the hip, we have the spines that is more common among Filipinos. Probably if there's involvement of the elbow, then you might have to look into occupational risk factor or even lifestyle risk factor that may have predisposed patient to develop elbow OA. And I think a lot of patients that complain with elbow pain, the main differential would be to rule out soft tissue rheumatism in these patients. So some of them might just have what we call the tennis or the golfer's elbow, and this can be easily managed with pain relievers.
Perfect, thank you. Let's see, what is the next question? The next question from an anonymous attendee. What is MSM? This is included in food supplements, chondroitin and glucosamine. And if you would know how it is taken, to be taken daily.
MSM, I think from what I remember, it's methyl sulfonyl methane. I think that's what it stands for. It has been here for more than a decade already. It has been marketed together with chondroitin, glucosamine as a part of the combination treatment for supplementation. But even with MSM, there's actually not enough evidence to support the use of this for osteoarthritis. The best evidence we have would be for glucosamine, particularly the prescription grade glucosamine and the prescription grade chondroitin sulfate.
Okay, thank you. The next question we have on our chat box is about diagnosis. In case RF is non-reactive or negative, do we need to test for anti-CCP if the ESR and the CRP are high?
Okay. Usually now in the recommendation for diagnosing rheumatoid arthritis, I think this question is coming from a point of view of rheumatoid arthritis. We already request for both rheumatoid factor and anti-CCP. And the reason for this is because there are times wherein only one will turn out positive for these patients. So if both are positive, then that gives you more of a prognostic value other than the diagnostic value for this patient. So yes, if it is RF negative, and then you're still thinking of rheumatoid arthritis, then you can go ahead and request for anti-CCP.
Okay, so that was more for rheumatoid arthritis than osteoarthritis. Does gouty arthritis affect tendons and muscles? Many things.
Yes. Yes, because your uric acid crystals can actually deposit in these tissues as well.
Perhaps this was addressed in the lecture, but there's a question here about Voltaren gel being applied to affected knees. And is it recommended or safe to use?
Yes, it's recommended, particularly if there is contraindication to use oral NSAIDs, or your patient actually doesn't like to take anything oral or medication, then you can use topical NSAIDs. Another thing that is probably not utilized very much in the Philippines is the use of patches. So aside from topical gels or creams, you can also use patches for these patients.
What are available as patches, sir?
There's a ketoprofen patch that is available. You can use it once or twice daily, depends on your activity. It lasts around 8 to 12 hours. So if you're going to use it only during your waking hours, then probably one patch would be enough, and then don't apply anymore in the evening.
For nutraceuticals, how long are those given for? Is it for life, for as just for symptoms, or what is the most studied duration?
Actually, for glucosamine and chondroitin, we use it as a single supplement because studies have shown that combining them actually decreases the efficacy of either. And then if you're going to give glucosamine alone, actually, if it's effective, then you can use it indefinitely. The longest study that has shown efficacy for the prescription grade glucosamine has been 3 years. And in this patient, it has been shown to decrease pain and even joint space narrowing. Now, when do you monitor whether this patient already has efficacy with the use of glucosamine? You can actually test whether it's effective already within 1 to 3 months. And if your patient is telling you that the pain has significantly decreased with decreased utilization of pain medication, then you can just tell the patient to continue with glucosamine.
Okay. Let me screen through some of the other questions here. We have a few more minutes in our Q&A. Here's a case question. For what advice would you have for a female in their mid-30s with knee pains, but is otherwise active in sports, actually moderate to high intensity, and then was diagnosed with osteoarthritis?
Okay, probably if well, you just have to identify your risk factor. If you're still overweight despite your activity, then probably you need to decrease the weight. Studies have shown, there are newer studies coming out, particularly with weight loss using GLP-1 agonists, and they seems to be effective in providing significant weight loss in these patients. And then if you're very active in sports, then make sure you do some precaution in not having injuries with these sports.
Okay. What foods are best to avoid or to consume in moderation for persons with osteoarthritis.
Okay. Again, probably this is coming from a concept of gout. Gout is different from osteoarthritis. The only thing that is related for food intake and osteoarthritis would be the weight. So the more food that you eat, the more you gain weight, and this is the relationship between food and osteoarthritis. But with particular food, there's actually no particular food that can predispose to osteoarthritis. This is more related to gout.
Okay, thank you for that, Dr. Chi. Now, we have come to the part of our webinar where we have run out of time. Once again, I would like to thank Dr. Lucero. We are very grateful for the time, your time and your expertise this afternoon. We present you with this certificate of appreciation. If our speaker has more time and more energy to spare, we invite him to answer the remaining questions in our Q&A box. So class of 1998 would also like to thank those who helped make this webinar possible: the University of the Philippines, Manila, the UP Medical Alumni Society, the Postgraduate Institute of Medicine, UP Information Management Service, and our sponsor for this webinar, Viatris. We invite all our viewers to join the next webinar about childhood constipation. Our expert speaker will be Dr. Evangeline Capul-C-Chianco, a pediatric gastroenterologist and a member of UPCM class of 2009. The webinar will be held on October 16, Monday, also at 12 noon. You can use the same Zoom link to register in advance or use the QR code shown here. To receive your attendance certificate, kindly answer the evaluation form, which you can access through this QR code. We will also post the URL in the chat box now. You will be able to receive your attendance certificate only after answering the evaluation form. Please ensure that the name you enter in the form is the name format that you want to appear in your certificate. So before we end this session, I would just like to do a shout out, happy birthday shout out to our resident ray of sunshine, Dr. Dennis Villarin, also a part of our class of 1998. So see you again next time as we continue to unlock knowledge for primary care workers and allied medical professionals. God bless you and stay safe, everyone.